to speak on which visual field strategy we should use.
Good morning. I'll be talking about which visual field strategy to use. The visual field strategies and the test patterns on automated perimetry, they run in tandem. We are all aware of the common test patterns that we use for glaucoma. 24-2, 10-2, and in advanced cases, the macular test. I'll be focusing primarily on the Humphrey field analyzer. The thresholding strategies have evolved majorly from 1980s when we were doing full threshold to eventually to fastback and then CETA standard. And in 2010, we saw that CETA fast and has progressed to even CETA faster. So that's what we would be talking about. We are all aware about these common test patterns, so won't be dealing much with them. Let's have a look at CETA standard, which is the traditional testing protocol. It's a full threshold strategy. It tests the primary points twice, giving you an accurate result. There is a standard grid pattern of 6-degree spacing, but it's quite time consuming. And as the patients get older and the disease advances, they take a lot of time to perform a CETA standard, and many a times you start getting unreliable results. Maybe when you do the first eye, the result is reliable, but by the time you move to the left eye, the result starts becoming unreliable. So I think it's best suited for baseline assessments and detailed monitoring of visual field changes over time, but once the disease starts progressing and patients, they start getting older, you can switch to another strategy. Time to switch to another strategy is best when the patient is stable, rather when you suspect there is some amount of progression, because then you really need to stick to the primary strategy that you're using. A step over CETA standard is CETA fast, which is a faster alternative. It uses an adaptive testing strategy that focuses on testing regions of visual field more efficiently. There is an intuitive element with this test. If you are a smart tester, the points would be projected to you at a faster pace, and some of the points the machine will fill on its own. It sacrifices some amount of precision and coverage compared to CETA standard, but it's a reasonable compromise, and in busy practices, most people now have started using CETA fast. This too can be used for routine follow-up and examination and screening purposes. The usual test time is much less than CETA standard, so the patients don't really fatigue as much. Coming to the newer kid on the block, that is CETA faster, which is available with HFA3, it further optimizes in terms of testing speed while maintaining an acceptable level of accuracy. It builds upon the principles of CETA fast. The clinical relevant information you can get in 3 minutes, quite fast, but there is still a major group of glaucoma specialists who still don't really rely on glaucoma faster, because it does tend to lose accuracy when we are talking about patients where critical decision making is to be made, especially when we are focusing at the central spots. CETA standard double checks the sensitivity at each spot. CETA faster, it's 50% faster than CETA standard, as I've already talked about. It removes the unnecessary dead time during the testing. There are no blind spot or false negatives. Entirely, it focuses on the gaze tracker to assess the reliability. So this image shows the first one with rim defect of a patient who was repeatedly performing bad on CETA fast. He wasn't able to do CETA standard at all. Once we shifted to CETA faster, the reliability as well as the test accuracy, it improved. So for some patients, even if they are young, they are just not used to taking up a longer test, a shorter test can help solve. So coming up to 24-2C CETA faster, we need to understand what was the problem with 24-2, which the computing engineers pointed out. So 24-2 uses a 6-degree grid in which only 4 test points fall within the central 8% of vision, and it does not adequately sample the macular region, which is occupied by more than 30% of retinal ganglion cells. And we know that even in patients with mild disease, there are several defects in the central vision. So going a step further, we have CETA faster 24-2C, which has optimum test points from the 10-2 pattern, which were added to the 24-2 pattern. And so we now have additional 10 points which focus on the center and help you to pick up the disease at a much earlier level. So simplistically put, 24-2, all points are being tested. When we go to 24-2C, These points which are marked in red, these are dropped intuitively by the machine. And when we step ahead to 24-2C faster, the points marked green are also dropped. So we are actually compromising on some points to get a reliable response. So this elderly subject with the unreliable 24-2 CETA fast, he performed better with 24-2C CETA faster, and for the first time the patient said that he felt confident doing perimetry. And every morning he had to come for the perimetry test. He was very anxious, but this test sort of reassured him that he can also do the test reliably. The test time dependencies on the visual field status as well as the results which the 3 algorithms gave have been shown to be quite similar in several studies, and this was one of the major studies which showed that the confidence intervals, they overlap over a whole range of threshold values. Still, there is a limited value of 24-2C, because if you get 1 point which in the central zone which is abnormal, you are not going to start your treatment unless or until you have 2 or 3 contiguous points in 24-2C central area. Now that too is not really possible because the number of points in the central area is still lesser than what you would expect in a 10-2. So it doesn't really contribute much to your decision making. So if you were having a patient with early glaucoma with 1 or 2 points in the center which were involved, you wouldn't really start treating this patient. So eventually we all would go back to the old 10-2 to sort of get more clarity on that point. So where to use 24-2C in glaucoma staging is still unclear. You can switch your patients from CETA standard or fast to CETA faster when patients struggle with the fields, when they have lumbar issues, or if you want a more targeted approach where the central defects are suspected. But remember that there is a challenge. The mean deviation values improve when CETA faster testing is performed in a longitudinal setting. So you have to keep in mind when you switch the patients. With regards to progression detection, CETA standard is slightly better than CETA fast and faster, but with HFA3, now you can fuse the previous different form of strategies and get all the form of strategies in the GPA summary, which allows you clinical equivalence of testing. So choose wisely and choose to strike a balance between repeatability and reliability. Thank you.
Thank you very much for this wonderful talk on perimetry.